and thank you for joining us for today's virtual education program at Cancer Support Community South Bay. I'm Rebecca, the program manager, and I welcome you to this workshop titled Radiation Treatment for Breast Cancer. Before we begin, if this is your first time joining us, CSC South Bay's mission is to ensure that all people impacted by cancer are empowered by knowledge, strengthened by action, and sustained by communities that no one faces cancer alone. We serve the South Bay, Long Beach, and Orange County area all at no cost. Our program includes support groups, networking groups, healthy lifestyle classes, social activities, and educational programs like this workshop. Educational programs are open to all. If you'd like to hear more about our services or join our community, please visit our website at cscsouthbay.org. Before I introduce today's speaker, we ask you to keep your microphone muted to eliminate any distracting background noise. Please feel free to enter your questions into the chat function found at the bottom of the Zoom window anytime, and we can get to as many as we can at the end of the lecture. Without further ado, I'll introduce our workshop speaker, Dr. Peyman Kabolizadeh, or also known as Dr. K, is the Long Beach Memorial Radiation Oncology Medical Director. Dr. K received his MD and PhD at the Medical College of Virginia and completed his Radiation Oncology residency program at the University of Pittsburgh Medical Center. He completed his fellowship in proton therapy at Harvard. Thank you so much, Dr. K, for being here with us today.
Thank you. Should I go ahead or?
Yes, go ahead, please.
And do you see my slides or?
One more time, please, to share your screen.
Oh, I see. Sorry.
Wonderful.
Just 1 second. All right. Thank you for inviting me. I will make it a lecture on breast cancer and radiation treatment. I'm trying to make it as less scientific as possible, so a little of scientific material from it. Hopefully is basic and pretty suitable for people. Let's go next. 1 second. Here we go. All right. So agenda items would be understanding breast cancer, principle of radiation therapy and radiation treatment for breast cancer, advances in radiation oncology, and outcomes and future directions. So first thing is understanding breast cancer. So as epidemiology and risk factor is one of the key points of breast cancer. As we know, the prevalence of breast cancer in the last 10 years is pretty stable, but the cure rate has been increasing, especially in North America, especially in the United States, and is among the most prevalent cancer globally. Risk factors is a combination of genetic and environment, but it's very important to identify the risk factor or at-risk population so we can do imaging and things like that a little bit early on to catch these cancers early so we can cure them better, so the rate of cure rate is higher. So the breast cancer accounts for 24.5% of all cancer cases in women worldwide. Approximately 2.3 million women were diagnosed with breast cancer globally in 2020. Regions with the highest incidence rate include North America and Western Europe. It's probably because we have a higher technology that catches any breast abnormality or cancer much in an earlier stage. What is breast cancer? Breast cancer is a malignant tumor that starts in cells of the breast. So types of breast cancer, the most 3 common ones that being treated is ductal carcinoma in situ, invasive ductal carcinoma, and invasive lobular carcinoma. There is other types, but they are rare and less frequent. So therefore, I just want to make sure that this is the 3 most common ones. Diagnosis and stage is very important because that's what directs your therapy. Diagnosis, it depends on what kind of imaging, what kind of biopsy is being used, and staging is if it is stage 1, 2, 3, 4. Again, it is very important to stage them very accurately because it directs your prognosis, the patient prognosis, and also it dictates the type of treatment and the course of the treatment. Both diagnosis and staging strategies is very important, and it pretty much directs the most effective care for patients' care, okay? So advances in diagnostic tools, mammography still remains the gold standard for breast cancer screening, but during the most recent years, we have added the MRI scan, which is much more sensitive and it catches very smaller nodules and abnormality in the breast that helps us to catch this cancer in early stage When we catch any cancer in early stage, the possibility of cure is higher. And ultrasound, as you know, is an effective adjunct to evaluating breast abnormality, especially in lymph node abnormality in axillary region. Recent staging technique that is being introduced into breast cancer is PET-CT scan, but generally we nowadays use it for advanced disease in breast cancer. Liquid biopsies are offer non-invasive staging option. However, they are on protocols only, like ctDNA, and also advancement in imaging technology improves staging accuracy. And that's, for example, MRI scan, newer MRI scan with higher Teslas and things like that. So what is the principle of radiation therapy? So mechanism of action is mostly to do with DNA damage in cancer cells. So this is what we were taught in research and also in med school, that radiation therapy damages the DNA of the cancer cells. It pushes the cells toward the process called apoptosis, and they die. The radiation can be delivered externally or internally. Externally is external beam radiation treatment. Internally is like brachytherapy. But sometimes we use the combination of both to target tumor effectively, especially every patient is different. So types of radiation therapy that we discussed is external beam radiation treatment, can be photon, can be proton, can be neutron, can be carbon ion, or brachytherapy, which can be involve radioactive material. But we use them for every patient differently. Even external beam radiation treatment has a lot of new technologies coming in regards to it to make it more individualized for the patient and more precise and accurate. Radiation equipment and technology is very important. Every year they get better and better. More technologies are being added to it to make it precise, to make it accurate, to make the radiation only go to the tumor sites and doesn't go to the area around the tumor. So the side effects and toxicities are limited. Linear accelerator is one of the machines that 99% of the country is using it for delivering of the radiation treatment. And these has been advanced significantly during recent years. The machines that was used in 1970s was, for example, cobalt. And advanced imaging techniques is very useful nowadays because we add those techniques to our machines. Linear accelerators or proton therapy, they have cone beam CT on them nowadays. They have X-rays on them. So to know exactly where the patient are or is at the time of radiation delivery. So if we know exactly where the tumor is at the time of delivery of the radiation, then it's going to be targeted delivery. So one of these newest technology is called exact track dynamic patient positioning. We do have this. The good thing is at Long Beach, we do have the most newest technology in the country, actually. And we're getting another machine that is actually, we will be the first in the whole world to have those technology, and we're going to have a peak view of that. So this is pretty much give a pixel by pixel GPS of your body and also a distribution of the thermal distribution in your body, what side of your body is hot or cold, what is the temperature of it. So if there is any changes, the machine follows it or stops delivering of the radiation. So any movement, those pixels can change. We use it generally in brain, but also we use it recently for the breast cancer. But the most important technology that is a big help for radiotherapy and breast cancer is Vision RT and Line RT, and is one of the most accurate and precise delivery system. Pretty much it gives you a very accurate high pixel GPS of your body, as you see here. And it's so accurate that it actually matches your face, and you actually can recognize a person by just the pixel by pixel. And it's very important in that because we look at the motion of your heart and motion of your chest wall. So we ask the patient, for example, take a deep breath, and this technology is so accurate, it knows that exactly where you are in your breathing rhythm. So when the breath is away from your heart, when you take a deep breath, and that's when the radiation is being delivered. And that's the beauty of saving the heart while delivering the breast radiation. Research program, future technology is very important in delivering of breast cancer radiation treatment. Especially, for example, in our institution, we have a lot of presentation. This is our physicist, Margaret, that presented on prone breast treatments, especially with using Vision RT. And this is just a peek overview of what's coming to here in North America, actually, what's coming to actually California. We will be the first few centers in the whole country to have this in the next 6 to 9 months. It's called dose map. So what it tells us exactly where radiation treatment will be delivered. We actually know exactly where it goes because um, uh, when radiation hits the tissue, it produces a different type of array, and this sensor actually catching it, and we actually know if the radiation went to the target itself or the area around the target. So we actually can modify the plan. So we actually know where exactly it goes, so we can modify the plan and decrease the toxicity accordingly. So radiation treatment for breast cancer. So when do we do it? Indication for radiation therapy is only post-surgery, or if it is inoperable tumors. We give radiation to shrink it, or we give radiation definitely or radiation palliatively, but majority of the time post-surgery, because the most important treatment of breast cancer for cure is surgery. So after surgery, we give radiation for multiple different reasons. For mastectomy, we give radiation if there is lymph nodes involvement. For breast conserving surgery, which is lumpectomy or partial mastectomy or quadridectomy, that means you still have your own breast. We give radiations to decrease the possibility of recurrence in the rest of the breast. So make it equivalent to the mastectomy. So NIH consensus statement in 1990s says breast conservation treatment, which is partial mastectomy or lumpectomy or quadrectomy. That means you keep your breast, is the appropriate method for primary therapy for majority of the women, and is preferable because it provides survival equivalent to the total mastectomy and axillary dissection while preserving the breast. It's a shorter surgery, less morbidity, less mortality, the same survival and local control. So this came from the trial that they did randomize patient to lumpectomy and radiation versus mastectomy, and that is where all it came from. All of this started from this trial that showed, hey, lumpectomy followed by radiation equal to mastectomy. There was no significant difference in local recurrence, no significant difference in distant metastasis, and no difference in rate of contralateral breast cancer. That means the breast cancer in the other breast. So it was equivalent. That's why majority of the women or men with breast cancer nowadays only get lumpectomy followed by a little bit of radiation, and that's equivalent to mastectomy. Now, goals of breast conservation, that means lumpectomy and radiation, lumpectomy followed by radiation, is to eradicate macroscopic foci of cancer with moderate dose of radiation therapy, not high dose. Minimize risk of local recurrence with maximal cosmetic outcome, because you still have your own breast and it's not a mastectomy. And maximize quality of life. That's the most important goals of breast conservation. So what is the patient's selection for breast conservation? The absolute contraindication is pregnancy. So we cannot deliver any radiation in pregnancy or pregnant women. Or multicentric disease. If you have a tumor, if the patient has a tumor with multicentric, multiple different lobes of the breast, then the cosmetic outcome may not be good with partial mastectomy, because most of the breast is going to be dissected and resected because of the multicentric disease. What are the relative contraindications? Or large tumor to breast ratio, again, if the cosmesis is not good after partial mastectomy. History of collagen vascular disease. These patients, like lupus, they have more sensitivity to radiation. History of prior breast irradiation, or inability to obtain negative margin. These are only relative contraindication. Given the modern technologies nowadays with more precision and accuracy, we sometimes still be able to deliver radiation treatment and save the breast. Can breast conservation be achieved without adjuvant radiation treatment? No, but can be or may be considered for some patients. And that came from 2 trials, but the biggest trial is the PRIME2 breast study overview. The PRIME2 involved thousands of patients, 1,326 patients that was randomized. They were all low-risk patients, 65 years old or above, and they all were estrogen positive tumors, and they all had adjuvant hormonal therapy for 5 to 7 years after surgery. And they were randomized to either lumpectomy or lumpectomy followed by radiation. to want to see if for low-risk patient, we can forego the radiation treatment. And the results was interesting. At 10 years, radiotherapy still decreased the possibility of recurrence significantly. The recurrence rate dropped from 9.8% over 10 years to 0.9% with radiation treatment. So there was a big discussion in this paper. It was actually pretty interesting. And the discussion was if this omission of the radiation treatment should be offered for low-risk patients if they have other comorbidities, if the physician believes that they're not going to survive more than 10 to 15 years, because after 10 years, the possibility of recurrence is above 10%. Therefore, radiation treatment is very beneficial. So for example, if a patient that is 65 years old, doesn't have any comorbidities, then you're gonna survive, she's gonna survive within the next 20 years, then radiation treatment should not be omitted because the cancer will come back. The risk of recurrence is high. So we have to, we try to give less is better. We have a saying, less is better. We try to do that, but we should also not undertreat and personalize, individualize the treatment for every patient. So treatment planning and delivery, pretty much that's what I was trying to say. The tumor characteristic is very involved. That means is it a lobular carcinoma, for example? How big is the tumor? What is the stage of the tumor? So if there are any lymph node involved, but also patient health consideration is very important. If a patient is 90 years old or 50 years old or 30 years old or performance status is not good, is bedridden. So those are all should be evaluated in the treatment approach with radiation treatment. And also that makes a difference in radiation delivery method. For example, you can forego a radiation treatment for a low performance status patient, or you can just do partial breast irradiation. So you have to individualize and personalize the treatment accordingly for each patient. It's to the discretion of the physician and the patient itself. What are the radiation techniques and radiation dose? So there are only two types. It's whole breast radiation treatment or partial breast radiation. The whole breast radiation treatment initially was 5 to 6 weeks. However, based on the 2 randomized trial, we do not need to give 5 to 6 weeks. We only need to give 3 weeks of daily radiation treatment. There is a new trial undergoing. We're trying to see if 5 treatments can be as good as 3 weeks of radiation treatment. Data is not mature, but looks good. I just offered it to a 90 years old with a high-grade disease. I think it is probably going to be the way in the future, but we just have to wait for the mature data, for the 10-year data to be published. Partial breast irradiation, of course, comes in 3 different types pretty much. Can be something called accelerated partial breast irradiation with intensity modulated radiation treatment. That's pretty much after surgery by external beam radiation, the radiation coming from outside, only 5 treatments of it. Or it can be done by brachytherapy. They put a balloon in the breast and we treat it with radioactive material for 5 consecutive days. Or it can be by intraoperative radiation treatment, only 1 shot of radiation at the time of surgery. However, that can only be offered for low-risk patients. Just an overview of intraoperative radiation treatment is only 1 shot of radiation treatment. It's based on 2 trials. One trial is Target, which came out first and shows the same results for whole breast radiation versus 1 shot of radiation at the time of surgery. However, the Elliott trial of the United States did not show that. Shows different. Shows that whole breast radiation was better than 1 shot of radiation at the time of surgery. That's why in the current National Cancer Institute guideline, IORT is not part of the guideline, only can be considered for low-risk patient and to the discretion of the physician. Other type of radiation, this is radiation with a balloon, which is called brachytherapy. The balloon is in the breast and attached to the radioactive material. And also the lower picture is just the radiation coming from outside with the 5 treatment every other day. You can also do partial breast radiation. Partial breast radiation can be offered to patients with grade 1 to 2 disease, tumor less than 2 centimeter, no lymph nodes positivity, estrogen positive. So pretty much low-risk patient, negative surgical margins, and no lymphovascular involvement. And again, so initially the age was a key factor. They only included 60 years or above. but right now the age decreased, I believe, to 40 years old and above. You can offer the partial breast irradiation. I think last year was 50s, but now it's in 40s, based on National Cancer Institute guideline. And this is just overview on partial mastectomy with sentinel lymph node biopsy and IORT, or intraoperative radiation treatment for low-risk patients. And this is done in Long Beach. We do have the machine. It's only one shot of radiation at the time of surgery. Now, the most important thing is side effects and management. I think that's the most important, that makes the quality of life, because a lot of times the physician only cares about curing of the cancer, but we also have to take into account the quality of life. And that's very important because the patient has to live with it. So the patient involvement in the decision making is very important. So the common side effects can be to do with skin irritation. That's the most common side effect, to do with skin irritation, increased color of the skin. Once in a while, we do see a bad sunburn. During the radiation, the patients will be seen by the physicians to make sure they're doing okay. They will be given different creams and things like that. We're going to go over in a minute. Fatigue can be also one of the side effects as well. Importance of the management is very crucial. The communication between the patient and the physician is very important to make sure that they are being taken care of and the right creams and right management is being given. Patient education is very important. That's why we have an education session before they start with radiation treatment, because we give them a booklet. We also go over everything, where to put the cream. You don't have to put the cream the whole body. It's only to the area that the radiation given. But unfortunately, if you don't have the education, you don't know where the radiation is going. So that's very important to know, to have that education session to know exactly where to put the cream, where the radiation is going. Common side effects is to do with the skin irritation, redness are frequent side effects. Patients may experience fatigue during the treatment course, and changes in breast textures and swelling can occur either during the radiation and also post-treatment. But all of these goes away very fast. During the radiation, it's very important to keep the treated area clean and moisturized is an essential. Therefore, there are different type of creams generally is offered, Aquaphor, Calendula. But the most important is use gentle, fragrance-free products to avoid any further irritation of the skin. Don't get a sunburn. Don't go outside near the beach to get a sunburn. Consult healthcare provider for effective topical treatment, because there has to be communication between the patient and the physician. Don't use random things because they saw it on a TV ad or the friend said so, because things can be different. Please consult the radiation oncologist to make sure the right things are being used and not irritate the skin further. Combating fatigue is very important. Rest is very crucial sometimes. It doesn't happen to every patient. And engaging to light exercise can help to boost the energy level, and also balanced nutrition is very important. And the most important is hydration. Well, hydration doesn't mean just drinking water. You just drink water, you just pee it out. You don't see an athlete to drink water. You see an athlete to drink Gatorade, Pedialyte. So hydration means Gatorade, Pedialyte, good soup, anything with electrolytes. That means hydration. Now, what is the long-term effect? Because, okay, we give anything that we do in medicine has side effects. Some of it called acute side effects. You get it, you feel it during the treatment. Some of it is late side effects. Anything we do in medicine, surgery, radiation. So what are the late side effects to do with radiation treatment? You can have long-term effects, may include changes in breast sensitivity. But you should continue and communicate with your physician regarding any side effects. The other side effects always happen over a long period of time, 5 to 10 years down the road. The affected breast that was radiated may look smaller, a little bit smaller than the other breast. It generally happens about 50% of the time. And also the skin of the radiated side may feel a little bit more thickened than the other side. That's pretty much most of the long-term side effects of radiation. But again, if any of them happen, please communicate with your radiation oncologist to see what are the management is for those type of side effects. Okay. Now, every year there is advances in radiation therapy, and that makes it less side effects, less toxicities, more accuracy, more precision, and that's very important to always research the places that is delivering the radiation treatment. And if you have a higher technology, you can personalize the radiation therapy approaches. to the patient's needs rather than just give whole breast to everybody. If you do have the technology, you can be partial breast radiation treatment. More, for example, for left breast cancer, you can do breast holes to avoid any radiation to the heart if they do have, if the technology is available in that center. So if they do have technologies, they can tailor the treatment plans toward that patient based on the prognosis, based on the performance status, based on the patient's age, based on the staging and diagnosis. And pretty much it's optimize the effectiveness of the radiation treatment while decreasing the side effects and toxicities and radiation to the surrounding structures. Okay. Now, outcome and future directions. It's very important to understand the short-term outcomes, which is acute side effects. It's very important to know the long-term outcomes. And also effectiveness and survivorship is very important. It's very important to know what is the prognosis is, what is the effectiveness of the radiation therapy is, and what is the role of survivorship, what is the prognosis, how many years have to be followed with the physician. Generally, the 5 years based on NCCN guideline with the radiation oncologist to follow up to make sure the toxicities are controlled. And also the effectiveness of radiation treatment should be reviewed by the physician. Now, all of this aside, the physical well-being of the patient is very important. And physical aspects after breast cancer treatment is crucial. And majority of the time, those are not addressed enough by the physician because the patient is diagnosed with breast cancer is going through a lot of stress, not just because of the diagnosis of the breast, but also because not anxiety, just anxiety, also because of the financial aspect of it, the insurance aspect of it. There is a lot of things that the patient is going through and the physicians are not aware of. So the physical well-being is very important during the radiation treatment and cancer treatment. Emotional support is very important, especially group and community involvement and support group. Those patients will do well. At the end of the day, is not the treatment of the cancer is very important. If the patient physical well-being and emotional well-being and support, those patients with great amount of those will do much better that patient that doesn't have those supports and well-being and emotional support. Because again, the body also helps in treatment of cancer. Now, future of research and emerging technology is very important. Every year there is improvement in technology of the machines, effectiveness of the radiation treatment, precision and accuracy of delivery. These will result in reducing the side effects, reducing the toxicities. And it's very important to know about them because there's a lot of research that's going on and there's a lot of every year there's new technologies coming out. That's why we are getting a new machine. We are very excited. Our machine right now is already new. It's only 2-3 years old, but we're getting another new machine, which is coming in 6 to 9 months. And we're very excited because it's going to have a lot of new technologies on it that can be used especially for breast cancer, because that's pretty much 80% of our patients in Long Beach. And it's very important to decreasing the side effects of toxicity and especially saving the heart and lung and all those things. All right, so the conclusion is we went through the breast cancer. We know what it is, the role of radiation treatment, especially in the setting of saving the breast. However, with post-mastectomy, we still give radiation treatment if they have lymph node involvement or positive margins. And the future advances that is to do with higher precision, higher accuracy, and less side effects, less radiation to the surrounding structures, surrounding organs. And that's it. I want to open the floor to the questions.
Thank you, Dr. K. First question. Does the 3-week whole breast radiation duration assume no lymph node involvement?
Yes, there are 3 to 4 randomized trials are undergoing for 3 weeks of radiation, even in patients of lymph node involvement. Sometimes we do offer that. The data is not fully mature, but we do have one trial with 10-year results that showed equivalent benefit to 5 to 6 weeks of radiation. So if you go to some of the academic centers, they do offer to some patients, 3 weeks for the lymph node positive as well. Astro, which is the guideline provider for radiation therapy, is not yet putting it in the guideline for the 3 weeks for lymph node positive, and the 5 to 6 is still a part of guideline for the lymph node positive patients, but I'm sure they're gonna change it soon. I think we're just waiting for the more mature data from the other trials. But yes, can be given.
Wonderful. Next question. How long does it take for the fatigue to go away?
So every patient is different. They did multiple studies. We actually don't know why fatigue happens in breast cancer. One of the reasons they think is probably because you come in every day and you have to get radiation treatment. Portion of it is subconscious and mental involvement, and portion of it is to do with hydration. Portion of it is to do with well-being and doing some exercise. So some patients takes about a month, some patients takes longer. It depends on the performance status of the patient initially. Also, if they are on estrogen blockers or hormone blockers, that also um, uh, can have effect on fatigue, because estrogen blocker also can have effects. So sometimes when I see a patient that fatigue after radiation is not yet resolved, I generally take them off from the hormonal blocker to give them a month to see if actually they get improved, to get back to their baseline, then start them again. So every patient is different. You have to um, you have to manage every patient individually for the fatigue. Fatigue is a very complicated issue.
Yes, thank you. How long after radiation and does the shrinking of breast tissue continue?
So generally is a long-term effect, but generally majority happen within the first 2 to 3 years of the shrinking of the breast. But the hardening of the skin, that's a long-term effect. So can happen 5 to 10 years down the road. But generally the shrinkage, 2 to 3 years after completion of radiation treatment, those are the pretty much the majority of the shrinkage that happens.
Yes, and this is just a comment. A participant recommends that another participant connect with an integrative nurse therapist in the practice to help manage side effects, both physical and emotional. So
Definitely.
that's just a comment. And then the next one is, and just to clarify, that is different than a nurse practitioner, correct?
What is different
An
than it?
integrative nurse therapist is different than your nurse practitioner.
Yes, yes, it is different than nurse practitioner. I think it is multiple support group and connections is very important. I think there should be discussion between the patient and the physician and radiation oncologist to make sure they are connected to the right people.
Wonderful. Next question. How can a patient help prevent capsular contracture on the radiated breast? Sorry.
Very good. So, very good. So, as you know, those are for implant patients. Sometimes they do implant for breast augmentation, for example, but this is for reconstructive surgery. As you know, the body reacts to any foreign material. So, implant is one of them. So, if a patient if a non-patient person has an implant, the body reacts to that and produce capsular retraction to it. And that's why the implant doesn't work more than 15 to 20 years, and they have to be changed, and the capsule has to be cut. The same thing with radiation treatment. What radiation treatment does is facilitate that effect. So if the capsular retraction happens with the implant supposed to happen within 15 years, with radiation, it happens within 10 years. So it facilitates that because it facilitates the response or inflammation around the implants by the body. What can we do to avoid that? Well, there is a lot of research going on. One of the things is sometimes the patient can get hyperbaric oxygen, sometimes they can get vitamin E and Trental, but in general, majority of the time is not significant reduction of that. That's why is not in the guideline. Sometimes you can take medications to decrease the fibrosis of breast surgery, but again, these are all on research and trials, so not much can be done. The only thing I always tell the patient is, you know, have physical therapy, especially if they have lymph node dissection. It's called for lymphedema clinic, and that also can actually help the fibrosis and capsular formation as well. But again, those are the things that are available. Hyperbaric oxygen, vitamin E, Trentol, those are for radiation effect.
Thank you. How long after radiation treatment ends should a patient wait before having implant-based reconstruction?
So that goes to your plastic surgeon. But generally, if they want to do expander at the time of radiation treatment, then generally they wait about 2 to 3 months. But every plastic surgeon is different. I have had plastic surgeons that wait 6 months. I have had plastic surgeons that only wait 2 to 3 months. So there is no right or wrong answer. I think it depends on the patient itself, how well she heals, and if the plastic surgeon is feeling comfortable to do it. Generally, sometimes they put the expander in and they expand before the radiation treatment, and the radiation treatment is completed. After it's healing, they switch the expander to put the implant 2 to 3 months after the radiation is completed. But sometimes also you just do radiation without the expander and they put the expander afterward. The cosmesis is a little bit better if they put the expander before the radiation treatment starts and then they switch it off. Now there is other type of reconstructive surgery which is called free flap. Those are a little bit different with radiation treatment.
Thank you. Next question. It's multi-question. Is chest wall lymphedema a common long-term side effect of the radiation treatment? What are the recommended treatment or prevention? And then is this a treatable condition?
Yes, it is a treatable condition. It's not a very common side effect unless they treated your lymph node, the patient's lymph node. Yes, physical therapy, and sometimes the centers has something called lymphedema clinic. We do have it here. If they have a lot of breast patients, they do have lymphedema clinic. And pretty much it's physical therapy directed toward edema in the radiation effect. Now, it's not just the radiation, it's also to do with surgery too. It both works together because you had surgery first and then you had radiation treatment. So it's a combination of both side effects. So yes, it is treatable. Pretty much physical therapy directed toward the chest wall and axillary region. The good centers or centers that treat a lot of breast cancer, they have something called lymphedema clinic. And they do give multiple different techniques, maneuvers, covers, things like that.
Thank you. Next question. Is there anything that can be done to prevent the shrinking?
Generally, the shrinking depends on the amount of radiation you get. So if you get partial breast radiation, the shrinkage is less. If you get a hypofractionated radiation treatment, which is just 3 weeks, the radiation is much less. So those studies on the shrinkage is done on 5-6 weeks of radiation treatment. So what can you do to decrease the shrinkage? So partial breast irradiation. Is hyperbaric oxygen, Trentol, and vitamin E? No, there's no data on that can avoid the shrinkage. I think shrinkage is, if anybody gets radiation treatment, there will be some atrophy of that organ. It's not just the breast. So less area of the breast radiation, less shrinkage. But again, cosmesis is one side. You have to also balance it with local recurrence on the other side. So if somebody with 45 years old with high-grade disease, I don't recommend partial breast radiation in spite of the fact that cosmesis is going to be great, outstanding. But I would recommend whole breast because the possibility of recurrence is high. You don't want this cancer to come back.
Absolutely. Thank you. Next question. For hyperbaric oxygen to help prevent capsular contracture, how frequently would a patient need to do those treatments?
So that's a very good question. There is no set guideline. You need to see the wound specialist and also the plastic surgeon. We generally, if you can write it, there's no rule. We can generally for 10 to 15 sessions, but there is no rule how many times, but generally at least 10 to 15 sessions is very adequate. I've had patients that had only 5 sessions. I've had patients only, it's not an easy thing. So patient gets bored during it because you have to be in a tube for a long time. There's an open area as well. There is a room as well. Everybody sits down with the full oxygen. So, but there is no, there is no set rule, especially for capsular contractions.
Thank you. If there are any other questions, feel free to put them into the chat, or you can unmute yourself and then let me know if you have a question to ask. But thank you so much, Dr. K. I think you covered a lot of information and really appreciate all that you shared with us.
Thank you. Thank you for having me.
Yeah, if I'm gonna wait 1 more minute just in case people are typing their question. Yes, excellent presentation. Thank you, Dr. K. Thank you, Dr. K. Yes, absolutely. All right.